You.
Thank you very much. Hey everyone, I'm Dr. Anderson, a current pain medicine fellow here at Stanford. Thanks for joining us today to continue our pain science lecture series. Today's topic is about the use of antidepressant therapies in the treatment of pain. So here's our outline. We're going to discuss where the use of antidepressant medications falls within our multidisciplinary approach to pain. And then we'll discuss why and how we use medications in the field before spending some time talking about the what, when, and whys for antidepressant medications in general. Then we'll wrap up with some information about specific examples. If you've been attending these lectures, then you'll be familiar with our field's current definition of pain, which was updated in 2020 by the IASP, or International Association for the Study of Pain. And it is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Pain is a personal experience with biological, psychological, and social environmental factors. And while pain itself evolved to serve an adaptive role, when it becomes chronic, it can have adverse effects on function and well-being. Now, when we talk about the multidisciplinary approach, we frequently talk about the 4 or maybe 5 legs of a chair. We have medications, physical and occupational therapy interventions like injections, minimally invasive procedures, neuromodulation like spinal cord stimulators, and also surgeries. We also very frequently utilize our excellent pain psychologists to assist patients in learning how to cope with experiencing chronic pain. And then finally, we will sometimes recommend complementary or alternative treatments as well. As this is a talk on antidepressant medications, we'll spend the majority of our time focusing on number 1 here, but I just wanted to keep the framework for our overall approach. So why do we use medications at all, right? In Western medicine, the medications we have in our arsenal are designed based on how we currently understand the body to work, which we call physiology. And we use them to prevent, slow, or stop a problem or process that is currently happening or may happen in the body. And we term such processes pathology or disease states. And while it isn't necessarily true of all medications, the risks associated with taking medications are generally lower than either procedures or surgeries. And also, in general, medications are cheaper than most procedures or surgeries and are therefore more likely to be covered by insurance. And then finally, they tend to work for most people to some extent, though finding the right medicine for you may require some trial and error. So how are medications used for pain? Now, we in the field of pain medicine will use medications one of 2 ways. And here I'm going to cover a little bit of lingo to help you communicate effectively with your provider. The first way we use medications is as needed, or PRN, which means that you are taking a medication as the need arises and not on a regular basis. The most commonly used PRN medications are actually over-the-counter medications, which we also call OTC medications, like acetaminophen or ibuprofen or naproxen for oral medicines, and then lidocaine or diclofenac gel for topical application. Topical application meaning applied to the skin. We also use medications scheduled, meaning at a set time. Oftentimes, we will schedule medications daily, or QD or QDay, twice a day, or BID, or TID, or 3 times a day. Now, it's important for you to know that PRN medications or treatments can actually be scheduled, and if a consistent effect is desired, for example, you can schedule Tylenol throughout the day to keep pain at a stable, lower level sort of throughout the day. And importantly, some medications, like antidepressants, actually need to be scheduled in order to work, as they require a consistent level of drug in your bloodstream to be effective. So what are antidepressant medications? So antidepressant medications are substances that were originally found to be effective for the treatment of major depressive disorder or related disorders, and noted to have improvement in pain as a side effect. These medications act directly on the central nervous system, which is comprised of the brain and the spinal cord, and they alter the way that cells of the nervous system, which are called neurons, connect with one another. And in particular, they are used to amplify the brain's own pain-killing mechanisms to reduce the pain that you are experiencing. Now, neurons themselves have one main job, which is to fire. And we call the firing of a neuron an action potential. And when the action potential travels down the neuron, it gets to a very small space called the synapse, where its chemicals are released onto the next neuron. We call these chemicals neurotransmitters, and they are used by neurons to communicate and connect with each other. After these neurotransmitters are released into the synapse, they are picked up by receptors, which I boxed down here in green on the bottom. And once neurotransmitters bind enough times in sufficient quantity, the next neuron itself will fire, and the process repeats downstream. Now, importantly, after the neurotransmitters activate the receptor of the next neuron, they are cleared from the synapse by transporters, which are boxed here in blue. And they're taken up by the first neuron that released them and broken back down and recycled into their component chemicals to be used again. The antidepressant medications we'll be talking about today bind to these reuptake transporters and stop them from clearing neurotransmitters from the synapse. And as a result, the neurotransmitters will hang around in the synapse longer and increase the rate of action potentials or firing from the next neuron. Now, there are many different neurotransmitters, and here are a few of the most commonly discussed ones. So on the top row, we have epinephrine and norepinephrine, which are also called adrenaline and noradrenaline. These two neurotransmitters are involved in the fight or flight response, but are also used in the brain. Then there is the related neurotransmitter called dopamine, which is in pink, whose role is to mediate the brain's pleasure pathways and also movement to some extent. And then we have serotonin, which is involved in regulating mood, and that is the common target for antidepressant medications. The ones below are equally important, but we'll spend less time talking about them today. Then, as an aside, the neurotransmitter in orange here, and which represents one of the original chemicals that endorphins, which are the original chemicals that bind to the opioid receptors, that also bind to drugs like hydrocodone and morphine. So why do we use antidepressant medications for pain? Importantly, pain is a nervous system function, and the purpose of which is to protect your body from actual or potential tissue damage. But sometimes pain can last way beyond a period of injury, like chronic back pain after a fall, or sometimes pain itself can be a primary problem without any clear injury, which is the case for patients who have migraine or have fibromyalgia. The pain in all of these cases is considered to be dysfunctional because the pain signals are no longer serving their intended purpose of protection. And for these situations, we'll often reach for medications that act primarily on the nervous system, because oftentimes that's where the dysfunction is thought to exist. So when do we use antidepressant medications for pain? So in general, there are two main reasons, both of which represent dysfunctional states of the nervous system. And these two reasons are neuropathic pain and nociplastic pain. Neuropathic pain is typically described as a pain that is burning, shooting, stabbing, cold, or shock-like in quality, and is secondary to or caused by an injury to a nervous system structure. The most commonly encountered neuropathic pain state in the US is the one caused by diabetic peripheral neuropathy, but there are other causes of painful neuropathy, like neuropathy that follows chemotherapy, for example, which can also respond to antidepressants. Neuropathic pain can also occur in the face, like in conditions like trigeminal neuralgia, where the nerve that brings sensation to the face starts to cause pain, or in occipital neuralgia, where the nerves in the back of the head start to cause neuropathic pain. Importantly, our medications are used to reduce the added symptoms like burning and tingling, and do not typically restore any numbness or reduce sensation that can develop from neuropathy. If anyone out there is diagnosed with multiple sclerosis or who has had a stroke in the past, Sometimes you can develop what we call central neuropathic pain, where the cause of injury is to the nervous system itself by those conditions. And then there's a condition called complex regional pain syndrome, or CRPS, that is often caused by an injury to one's extremities. And the pain of CRPS often has neuropathic qualities to it that can respond to these medications. Nociplastic pain is a relatively new term that is used to describe pain states that can sometimes have neuropathic qualities, like the burning, the stinging, the stabbing, or the shock-like pain. But there's no clear injury to the nervous system that has been identified. And sometimes conditions like neuropathy, or even conditions that are not clearly neuropathic, like chronic knee pain, which is thought to be musculoskeletal, can develop nociplastic characteristics. We consider pain that has nociplastic characteristics to be centralized pain, or pain that has developed what we call central sensitization, where the brain is perceiving pain to ordinarily non-painful stimuli. And conditions like fibromyalgia, migraine, or functional abdominal pain are thought to be primarily nociplastic in nature. And the good news is that these medications can work for conditions like these. So here's a question that some of you may be thinking. So if my doctor is talking to me about using an antidepressant, does that mean they think I have depression? It's a good question. And the short answer here is not necessarily. Just because we're asking you to try an antidepressant medication does not mean that we're treating your depression. Though sometimes people may find that their mood can generally improve on these medications. In general, the way that these medications are prescribed can be different for depression versus pain, and psychiatrists will often increase these medications much higher than we would for pain. And also, more importantly, improvement in mood can lag way beyond when pain can improve, perhaps even months after consistent taking these medications. And sometimes patients can notice their improvement in pain quite quickly, even starting low doses of these medications. As an aside, I would encourage you to seek help from a psychotherapist or a psychiatrist if you feel like you have, or you've been told you have, a serious mental health condition. Personally, I will often recommend I'll make recommendations for pain management rather than starting one of these medications myself, or patients who I feel need to be co-managed with a psychiatrist. Now, what are some commonly used antidepressants for pain? And medicine as a whole will sort our medications based on their function or their chemical structure. One class of drugs that we use for pain is called the serotonin and norepinephrine reuptake inhibitors, or SNRIs for short. Some medications here include duloxetine, venlafaxine, the related drug desvenlafaxine, and milnacipran. Another commonly used and older class of medications are called the tricyclic antidepressant medications, named after their three-ring structure. Examples include amitriptyline and the related drug nortriptyline, as well as desipramine and its related drug imipramine. Importantly, not all antidepressants are used for pain. For example, some of you may be on drugs like fluoxetine or sertraline, escitalopram or citalopram, and these drugs are used mainly to treat depression and anxiety disorders. Though, because chronic pain tends to have a suffering component, you may find that your pain can improve as your mental health improves in general, but they are not thought to act directly in a way that improves pain. So here's a somewhat complicated picture of the synapse that I talked about earlier. So on the top, we have a synapse for a neuron whose job it is to fire and release a neurotransmitter called norepinephrine. And then on the bottom, we have a synapse for a neuron whose job it is to fire and release a neurotransmitter called serotonin, which is listed here as like 5-HT. For the SNRI medications, I'll direct your attention to the green box in the center of the screen. We'll see the letters SNRI shown. Here, this picture is indicating that the SNRI medications, like duloxetine, venlafaxine, or milnacipran, will bind to the transporter proteins called NET, which stands for norepinephrine transporter, as well as SERT, which stands for serotonin transporter. And as I mentioned a few slides back, the purpose of these transporters is to help clear the neurotransmitters norepinephrine and serotonin from the synapse, and therefore reducing the amount of chemical that binds to the next neuron. So when you take an SNRI medication, they'll bind to these transporters, these reuptake transporters, and stop them from functioning, which increases the amount of neurotransmitter in the synapse, and thus the amount of firing the next neuron does will increase. The mechanism by which increasing the chemicals reduces pain is a subject to research, but probably involves the amplification of the brain's own pain-killing mechanisms, thereby reducing how much the painful sensory input draws your attention. We'll often tell patients that the goal of our medications is not to take pain away completely, but rather to reduce it to the point that it no longer causes a high impact in your life, and then you're able to function better than before. So that's the main goal. So here is some more detail for some commonly used medications, and I've also listed some cash prices. So this is not with insurance, it's cash prices. So on the left, we have my favorite medication, which is called duloxetine. It is used in conditions like migraine, neuropathy, fibromyalgia, functional abdominal pain, and is also used for patients who have chronic joint pain with central sensitization, like chronic knee pain, like knee arthritis with central sensitization. I personally will typically start low and increase slowly over time. For this medication, I'll start at 20 or 30 daily and then increase every 7 to 14 days. Some side effects with duloxetine include GI upset, feeling more awake or more activated during the day. And sometimes people can feel somewhat constipated at higher doses, and this drug can also have an odd sort of withdrawal syndrome where patients will describe what they call brain zaps or other body tingling sensations when it's withdrawn abruptly, when you stop it quite suddenly. And if this happens to a patient, I'll often reduce the medication even more slowly by doing alternate day dosing. Venlafaxine in the middle, it's a medication that's similar to duloxetine and is sometimes associated with increases in blood pressure, so caution should be used for patients with difficult to control blood pressure. And then milnacipran, as you can see here, is much more expensive if you were to pay for it out of pocket, and has a special indication for fibromyalgia in particular. In general, I favor this class of medications because they tend to be more activating and are weight neutral, which is an uncommon feature when using medications that act on the nervous system. For example, if you or someone you know is on gabapentin, which is an anti-seizure medication that we use a lot more commonly for neuropathic pain nowadays, you'll know that it's typically associated with increased fatigue, maybe some brain fog and weight gain. So it's uncommon to have medications that affect the nervous system that don't have those symptoms. This is the other class of medication called tricyclic antidepressants. It's an older class of medications that act on the same transporters that the previous class did, with the added action of blocking. If you look at the picture, there's a green box for TCAs, blocking the alpha-1 adrenergic receptor up top, as well as a variety of other receptors like histamine receptors and acetylcholine receptors, which are some of the neurotransmitters I mentioned before. And it can result in increased side effects when using these medications. And on the bottom left, I'm showing my second favorite medication called dizipramine, and we'll see why on the next slide. You can see the three-ring structure here, which is where this class of medications derives the name tricyclic. The tricyclic antidepressants are very effective for both depression and for pain, but the drawback is, and this is true for most older medications, that they are associated with increased risk of side effects because they contact many different receptors. So dizipramine, which is the medication I just mentioned, is the medication that appears to have the fewest side effects in this class, based on its relatively increased selectivity or preference for the norepinephrine transporter. But we can see that these other medications are more associated with side effects like blurred vision, cognitive clouding, dry mouth, constipation, low blood pressure with standing, which is called orthostatic hypotension, fatigue, sexual problems, urinary retention, and also weight gain, which is not listed here. That being said, if you're trying one of these medications, I would advise that you do at least give it a shot, as each side effect is not necessarily guaranteed for each patient, and everyone has a different level of tolerance for these side effects. And sometimes the side effects may even be desired. For example, if you're someone who has neuropathy, like diabetic neuropathy that keeps you awake at night, you may want to try a medication that will both treat your pain overnight and make it easier for you to fall asleep, like amitriptyline or nortriptyline. So here's a breakdown of commonly used medications from the TCA class. In general, because these medications are older, they tend to be cheaper if you look at these cash prices here. On the left is the oldest of the TCAs, called amitriptyline. It's used for many neuropathic and nociplastic states, like diabetic neuropathy, migraine, and functional abdominal pain. Nortriptyline is derived from amitriptyline and is thought to have fewer side effects. So most people will reach for that one before amitriptyline, but it probably has a similar efficacy or effectiveness. And then finally, dizipramine, which is a great medication because unlike amitriptyline and nortriptyline, it usually doesn't result in most of those aforementioned side effects like weight gain, fatigue, and constipation. So that's it. That was an overview of antidepressant medications for pain. And as always, we'll take it back to our overall multidisciplinary approach because we find that patients who take part in these different approaches generally do better in the long term when it comes to reducing pain and also in restoring function. And so this is the final slide that has some additional resources. And that's it. Here's some